Anyway, let's jump from rabies to bronchiolitis. And there are about 5 or 6 major points to go through in this chapter. The first question is, can you, by fever, by height of fever curve or whatever else, distinguish those with bacterial infection and those with not? First off, height of fever. The answer, if you're talking less than 40 degrees, is clearly you can't distinguish viral from bacteria. When you start to look at series in infants of children that had temperatures of 41 degrees or higher, there's a few things that come out in that sort of rarefied literature. First off, a very high percentage of those infants will have bacterial infections. But the second thing is that none of these infants look well. They all look really sick. So the infant with a temperature of 42 degrees who looked great was just not described in these articles. So at least within the normal temperatures we see, you can't distinguish bacterial from non-bacterial. With fever pattern, how often it goes up or down, also you can't distinguish. And the response, whether or not they respond to antipyretics, has nothing to do with whether it's bacterial or viral. Next question to be asked in this chapter is, do first-time wheezers need a chest x-ray? So here's one study, number 3, 265 first-time wheezers. This is actually a prospective study, and they've trained the emergency physicians or retrained them in how to look at x-rays of kids with bronchiolitis, and they still found that about 15-20% of the kids were being given antibiotics. In the study, one child had a lobar pneumonia, another child had cardiomegaly, otherwise all the chest x-rays were consistent with bronchiolitis. The conclusion of this study is that a chest x-ray is not routinely required. And at least certainly when I reflect on my practice, if I see an infant with what clearly looks like an upper respiratory infection and they don't look that sick, I certainly don't chase after with an x-ray. And that's probably who they're talking about here. Not to do. I am going to assume that most of us in this room, if they're sick enough to be admitted to the hospital or intubated and put in the ICU or something like that, we'll probably get a chest x-ray on them. But now a lot of these will end with the American Academy of Pediatrics. What they recommend chest x-rays should not be routine. I don't know if you ever go to their website. Their website is rich with some great stuff. I particularly recommend the section on, does your child use inhalants? That section. What are the clues? And they have some clues there like, your child smells like gasoline or whatever else. But if you have a 10-year-old child, and this is a quote, finding a can of gasoline under your child's bed might be a clue that they are sniffing inhalants. So that's good stuff. Now, we're seeing infants all the time and raising with fevers and ask the question, could they have a bacterial infection? We've sort of stopped the whole mega workups, and we're sort of left for the most part. If I'm a 2-year-old and I have a temperature of 103 and I have no source and I look great, probably most of us in the room will check a urine and then be done at that. So the question is for bronchiolitis, if you have a clear source, how often will you find actually a serious bacterial infection? And if you look at these series of articles, 4, 5, 6, and 7, you come up with the same answer. About 1 or 2% of them, if you do urines on all of them, will have bacteria in their urine. I will refer you to one study. It was a wonderful study that asked the question, made the following postulate. We do get urines, and the urines are and some of these urines will have positive cultures. How do we really know that what we're seeing in the urine is actually causing the fever or the problem with the child? So this was the study, is that they took infants with fevers and they classified them in 3 categories. One, it's very clear, it's very obvious to me that you have upper respiratory infection or something as a cause of your fever. 2, I'm pretty sure what's causing your fever, but I'm not 100% sure. And 3, I have no idea what's causing your fever. Well, in the third group, 7% of those babies had positive urines. In the middle group, 5% had positive urines. And in the group where I have a clear diagnosis, it was 2 to 3%. So what these authors postulated is probably if you just grabbed a bunch of kids out of a kindergarten class or a pre-K class and did urines on them, you'd probably get 2 or 3% with positive cultures. So whether or not this is significant or not, unknown. Whether or not every child should get a urine test, who knows. If you do get them, though, it does seem pretty clear that you need to cath them, or else you're going to end up with a lot of kids getting positive cultures. If you have an ultrasound machine in your department, it's nice to establish as a matter of absolute routine that no catheter goes into an infant without first looking to make sure that the bladder's full. Now, what about the very young with RSV? How often do they have another source of bacterial infection? And Article 8 looks at that. And they separated the kids out. All these kids look like they have, or infants look like they have upper respiratory infection. Now I'm going to test them for RSV and separate them out into the groups that have RSV or not. The group with RSV, 7% had bacterial infection. The group without RSV, 12%. This is less than 60 days old. And in the 30 to 60 day, all the cultures were urines. But less than 30 days, if they came in with fever and looked like upper respiratory infection, 12% of that group had findings of bacterial infection, either mostly urine and blood culture, no meningitis. But their recommendation from that article is you actually still need to work up a 30-day-old or less with a fever. Now, what about adrenergic agents? If you look, there's a huge number of studies on this, and based on all these studies, you can come to some very crystal clear conclusions. Is that A, it might not work for bronchiolitis. B, it might work a little bit for everyone who has bronchiolitis. Or C, it works a lot for a small number of kids with bronchiolitis. And based on, if you tease out this literature, the latter possibility seems to be the best. There are some studies where it didn't make a difference, but the trend in the studies is that albuterol is somewhat helpful. Not dramatically so, but somewhat helpful. Now, I don't know how familiar you are with the literature on asthma and treatment with Atrovent in kids, but the literature on that is actually pretty consistent across a number of studies, and the number is 10%. And it's not that adding Atrovent makes the kids 10% better, it's that 10% of the kids are responders to Atrovent and 90% aren't. And there was no historic element that you could pick out that would say this kid's going to be a responder to Atrovent and that one not. So a lot of people practice, at least with their first neb, to always include Atrovent, even in children who supposedly aren't supposed to respond. So I think this probably pans out for both the adrenergic agents and steroids. It's not that everybody responds a little bit, but some people respond a lot. And that's one of the tricks in the literature on bronchiolitis, is because one question is, does bronchiolitis respond to these things? The second is bronchiolitis a diagnosis of definition? Meaning, I have bronchiolitis if I didn't respond to these things. If I did respond to adrenergic agents and steroids, then it's not really bronchiolitis, it's just reactive airway disease. But the AAP, their official position, try it, continue it if you get a good response. Otherwise, don't worry about it. When we go to nebulized epi, the answer in articles number 12, 13, and 14 is that nope, epi didn't help. No, no, and no, all three of those articles. But now let's do something a little different in articles number 15, 16, and 17. Either using inhaled epi or using inhaled terbutaline, let's mix the terbutaline and saline, or let's mix it in 3% in hypertonic saline and see if there's a difference. And in all three of these studies, mixing it in hypertonic saline either had a modest or dramatic effect on the child, decreasing length of stay, decreasing admission, or in one of the studies, just a sort of a modest improvement. But this, you're 3 for 3 here in articles that say if you use hypertonic saline instead of regular saline to mix this stuff for bronchiolitis, that this is something that will work. Unfortunately, hypertonic saline is not expensive, so it's hard to get people to adopt it. Steroids, most of the studies on steroids and bronchiolitis, again, show really not much benefit. But please remember, many of these studies are on children who were admitted with bronchiolitis. So those of us that see people in the emergency department, and actually, I was meeting with our PEDS ICU group because they never like anything we do. We can't do anything right. But one of the examples that the PEDS ICU attending is every patient admitted to us with bronchiolitis is on steroids, and that's just stupid. And I asked her, I said, if it has ever occurred to you that this is sort of definitional, the reason we're admitting them is because they failed steroids, is that the ones that got better we've sent home, so you never see them to begin with. And she said, yeah, I guess that's right. You know, the literature doesn't really support it. Even though when my 5-month-old had bronchiolitis, I gave her steroids, and it seems like she got better. So I did not quite understand how this conversation was going. But I got the point that I'm wrong and she's right, and that was the important part of it. So that was fine. We were happy. Number 18 is an article on admitted patients, and they say, yes, Decadron did help. 19, admitted patients, no, it didn't help. 20, nebulized budesonide, no. For the most part, the literature on nebulized steroids in the emergency setting is a weak effect at best, is that they need systemic steroids. There's a few articles I've seen, one was in kids and one was in adults with asthma, that looked at nebulizing Decadron and its impact on the length of stay in the emergency department, and it seemed like you got better substantially quicker with nebulized Decadron than without. So that's maybe something to tuck in the back of your head. There was also a study that compared, and this is very useful for someone that you're worried they're not going to go to a pharmacy or don't have any money or whatever else. Typically, we'll give a 5 to 7 day dose of oral steroid. That was compared with giving one dose, this is for asthmatics, giving one dose of Decadron in the emergency department and then one dose, just give them the dose to take home with them to take the next day. So they only get 2 doses, and that was equal to a 7-day course of prednisone. So another trick to sort of keep in the back of your mind. So Article 21, oral Dex worked. The 22, Dex worked. 23, this is on 600 patients, a prospective trial, didn't seem to work. So the AAP's official position is it should not be routinely used. I have to admit I have not been able to convince myself not to use it because I am convinced that I'm seeing some infants with reactive airway disease and it makes a difference and they go home. So maybe it's irrational on my part. How many of you will routinely use steroids for at least one dose for bronchiolitis? And how many don't? Okay. Well, the don'ts have it. Heliox. Anybody here use Heliox for bronchiolitis? Going once, going twice? Now, all of these, we'll talk about CPAP tomorrow. All of these articles are administering Heliox with CPAP. So whether it's the Heliox that's working or the CPAPs that's working, but all of these articles, 24 is a review, but 25, 26, 27, in all cases, if you gave them Heliox, not only did they talk funny, but they actually were better as a result of getting the Heliox with the CPAP. Ketamine, there's an article on ketamine here talking about mechanical ventilation of children with bronchospasm. This is a wonder drug for asthma. There's been a number of cases reported where the patient's crashing, burning, you can't ventilate them, so now I'm going to intubate them. I give them ketamine in preparation for intubation, and they no longer need intubating. The first time I ever used ketamine for asthma did not save the person from intubation, but once he was intubated, he had these very nice low airway pressures, easy to ventilate. After about 30 minutes, the airway pressures built higher and higher and higher, and they were just popping off the pressure valve, and he couldn't be ventilated. And he was getting continuous nabs through the ventilator. Gave him a dose of ketamine, and within about 2 minutes, his pressures dropped back down to in the 20s to 30s. So he required repeat doses of ketamine, when quite honestly, nothing else seemed to work. He was getting maximum dose nabs, he got steroids. Finally, after about 24 hours, he turned and got better. But remember ketamine as really the wonder drug for someone with bronchospasm who's crashing and burning on you. or you want them to have a trip while they're in the emergency department. Immunoprophylaxis. This is acute study not on the efficacy of immunoprophylaxis, but the cost effectiveness of it. And it broke the cost effective studies down into, were these cost effective studies funded by the manufacturer of the agent, or were they not funded by the manufacturer of the agent? So you already know what the answer to the study is, so I don't need to even say it. If it was not funded by the manufacturer, it was not cost effective. 31 is RSV and apnea. Since there's an association between the two, what is it that we need to do with kids with RSV? Is there any magic number? Does anybody here have an automatic, if I see somebody with RSV at such and such an age, they automatically get admitted, or is it always clinical judgment? Everybody just use the clinical? Well, they ask who's going to get apnea. So here's some subtle clues. This was a 700 patients retrospective chart review, and they're all admitted. And so who of these, so these were all pretty bad bronchiolitis. Who of these actually had problems with apnea? So if you're full term but less than a month old, if you're preterm but your total lifespan was less than 48 weeks old from conception, or the other risk factor for apnea was witnessed apnea, so that's an easy one to remember. And if they didn't have one of those three things, none of the infants that were admitted to the hospital had an episode of apnea. So it's really prematurity, the very young, or someone having actually witnessed the apnea. So the last section here is who needs to be admitted and who doesn't. 32 is a retrospective review where they try to develop some criteria, and there's none that they seem to work out. 33 is a prospective study of 1,400 kids with bronchiolitis, and they ask who's safe to send home. So basically it's who we would send home. You've got a good pulse ox, you're breathing easily, you don't have any retractions, you look good. Once you met that criteria and you went home, according to this article, still about 7% of these kids bounced back in the next 24 hours. Other than that, they didn't report any horrible outcomes, but it is something when you're discharging somebody that works great. I guess it's wise to tell the parents, you got about a 1 chance in 10 that you may need to come back, and we'll have to either treat you further or admit you. So that's that for bronchiolitis. Any questions or comments or arguments or fights or anything before we go? Yeah.